and we appreciate all of you being participating in this. And I think you're really going to like this one. The title is Value-Driven Pharmacy Benefit Strategies to Curb Costs and Improve Outcomes. And before I introduce our two speakers, I just want to say that employers expect their health benefits costs to increase 5.3% this year to an average of $15,500 per employee. I got that out of a recent article. I think it was Employee Benefits News. And here's the deal. Costly biologic therapies and wasteful spending due to medication misuse, overuse, and underuse are the key drivers behind employers' rising healthcare costs. There are some new instruments in the toolkit, the drug management toolkit, that I think you'll find very interesting. That's what we're going to talk about today. One is biosimilars, and the other is the comprehensive medication management. So with that, I'd like to introduce our two speakers, Sandra Morris and Kim Forster. Sandra is the senior advisor with Get the Medication Right Institute. Sandra also, she doesn't let any moss grow under her feet. She is the former director of benefits for P&G, Procter & Gamble, and that's where I first got to know her, and her incredible knowledge and insights about developing strategies, benefit strategies. And the medication side, or the pharmacy benefit, is one of the key areas where she's shown some real innovation. So she joined the Get the Medication Right Institute as a founding member in 2019 to support the vision of enhancing life by ensuring appropriate and personalized use of medication and gene therapies, and the mission of bringing critical stakeholders together to optimize outcomes and reduce costs by getting the medications right. And this is their Dallas-Fort Worth Business Group on Health is a member of the advisory group for Get the Medications Right Institute, and we've been privileged to be kind of in on the ground floor to see all the wonderful work that they're doing that I'm really excited that Sandra will be talking about. Kim Forster is the Director of Pharmacy Account Management for Blue Cross Blue Shield of Michigan. She's got over 20 years of healthcare experience across various markets, giving her broad and balanced expertise. But prior to joining Blue Cross team, she was a vice president for a prominent pharmacy consulting firm where she facilitated the pharmacy vendor contracting negotiations and oversight to ensure accountability on behalf of health plans and self-insured employers across the country. Kim has a lot of expertise and knowledge about the biosimilar market, and I think between the two of them, Sandra and Kim, we're going to have a very interesting and informative discussion about, as I said, two management tools, pharmacy management tools in the toolkit, the medication management, comprehensive management, and biosimilars. So with that, Sandra, it's all yours.
Thank you, Marianne. Hello, everyone, and I'm glad you could join us today, and I'm glad to be a part of this. I want to start out with a quotation from someone that I always found to be a wonderful entertainer, but also a scholar for children. The quote is, "When I was a boy and I would see things that are scary in the news, my mother would say to me, 'Look for the helpers. You will always find people who are helping.'" And that's Mr. Rogers' quote. There are many scary things in the news today, and there are a lot of helpers out there that are working on these types of things. For employers, there's a lot of different scary things going on. For example, we have over $450 billion marketplace in prescription drugs, and 70% of that marketplace is being controlled by 3 pharmacy benefit managers. The less oversight that is given, the more we seem to be going down a rabbit hill with our PBMs, and employers are looking for ways to say, how do we know what's going on? How do we talk to our PBMs and our medical carriers? And what do we say? What do we ask them about the care that's being given to our members and what they are actually administering for our healthcare plans? We have a good reason to ask those questions. We are the fiduciaries for our healthcare plans. And what that means is, by law, we're required to act prudently when it comes to utilizing our benefit dollars. And what we are finding, the more that we look into the different aspects of our administration, the more we're discovering that there's not a whole lot of prudency going on within the way that our plans are being managed by our carriers. And we are the ones that are liable for that. When we look at that cost, for example, of brand name drugs, the drugs made by multiple manufacturers, including Janssen, Eli Lilly, GlaxoSmithKline, Novartis, and Sanofi, all of the cost for their brand name drugs decreased in 2020. Did your drug costs decrease in 2020? I think the answer to that is no. So what's going on? What should we know? Specialty drugs, huge part now of our pharmacy benefits spend. More than 50% of most employers' pharmacy benefits spend is on specialty drugs now. And 70% of the 7,500 plus drugs that are currently in the pipeline are specialty drugs, and they will be used to treat the very high cost conditions that our members are experiencing out there. So that's 70% of 7,500 being specialty. That tells us what our future is going to be when it comes to the specialty drug market. So what's happening in the market in terms of employers? There is a resounding cry of these costs are not sustainable. We cannot continue to offer the benefits that we're offering employees at this point in time when we've got something looming over us like specialty drug cost and the amount of cost that's being spent now and that will be spent in the future. So the smaller employers are already looking at eliminating coverage for specialty drugs and leaving it up to their members to decide what they are going to do to be able to access those drugs. Now, granted, these employers are employers that tend to have high turnover rates among their employees, and that's just a strategy they're doing to be able to maintain offering any benefits to a high turnover rate employee base. But other employers are doing different other things, and a lot of that has to do with increasing the cost to the actual members. And we'll talk a little bit more about that in the near future here. What else is going on? States remain at the forefront of new drug pricing legislation. In 2021 alone, 650 proposed state laws have occurred, and more than 30 of those have passed. Now, what will happen with all of those different state laws in place when the federal government steps in? And it's not a matter of if the government is going to step in, it's a matter of when. It's going to happen, and what we're going to see is a lot of variation from state to state in terms of what the current legislation is, and then a lot of oversight by the feds saying, no, we're all going to do it this way, and it's going to create a lot of disruption among our members and a lot of cost for us. The other interesting thing that has occurred that is pretty scary is that in 2020, the rates of preventive cancer screening bottomed out in terms of what they were compared in 2020 to 2019. People simply are not getting their preventive screenings, and in particular, they're not getting those screenings for cancer. Now, cancer, as we already know, is a huge cost area for all employers, and what we are going to see in a very short period of time is we will see patients that are presenting with much more advanced stages of cancer than we saw before COVID. People are still afraid to go into the medical facilities to get these types of tests done. So again, as employers, that should be a scary point for us and something that we should be looking into. Now, what about those PBMs out there in the medical carriers? they're not helping us much when it comes to the impact, particularly of the specialty drug cost. It used to be that clinical outcomes and lower cost were the drivers for formulary development. In other words, they would look at the clinical outcomes of all of the drugs within the class. They would look at those outcomes comparing each other in terms of clinical efficacy. And then they would also look at the cost of the drugs. And that's how our formularies were developed. Well, that has gone completely almost by the wayside. What is driving formulary development today are the financials. How much of the rebate can we achieve by putting one drug on the formulary as preferred versus another? And if it is a point where several different drugs within a class actually have the same clinical efficacy, that doesn't mean that your formulary is going to contain the drug that has a lower cost. Now, you may say, well, that's not so bad because we have 100% pass-through of rebates, and we're getting money anyway for those drugs being on there because we're at least getting the 100% pass-through. Well, the reality of it is you probably are not getting 100%, even if your contract says it's 100%, because there are a lot of things that are being hidden in other titles, if you will, that are monies that are coming from the drug manufacturers as part of the whole rebate deal, but in actuality is being called something different than rebate money. But the scarier thing about all of this is that around 70% of the patients who are prescribed any given biologic drug will not achieve the clinical outcomes that are desired. 70% of the people that are prescribed a specialty drug will not achieve the clinical outcomes. So that means we're looking at 30% efficacy of the majority of those specialty drugs out there. But folks, you're paying for them. They're being prescribed and you're paying for them, yet you're not getting any outcomes as a result of paying for those drugs. The human and financial impacts, for example, of formularies continue. UFC Schaefer Center for Health Policy and Economics did a study very recently that shows that for every $1 increase in rebates, there is a $1 increase in drug list price. So you have to ask yourself, are rebates really helping us as an employer base? And certainly are they helping our employees as well? So we haven't been real successful at controlling the cost of specialty drugs. And we're looking for answers. What can we do? What are the value add benefits that we can design for our plans that will actually deliver value and help us get a handle on a lot of what's out there? And I would say one of the first things that you should focus in on is supporting the price transparency rules that went into effect. Now, there's been some delay in that, but a recent report published by the New York Times has revealed significant differences in cost for the same exact procedure billed by the same exact hospital based on the carrier who is administering a particular plan. For example, an MRI for Cigna costs $1,019. For Aetna, it was $3,101. And for a third carrier, it was $3,809. Colonoscopy, cash. Person goes in for a colonoscopy and they're going to pay a cash price, $782. Same hospital, different way of paying, using, for example, Cigna, $14,063. Using Aetna, $21,044. Again, we have got to support price transparency, and that in itself is going to be a value add for employers. We've got to start paying attention to the transparency factors that are coming out and making sure that we start doing the right kind of education and providing the right kind of tools for our employees to make choices. And there are employees out there, for example, that say, I've got a high deductible plan, and if I'm being covered under, say, Aetna, I'm going to pay $2,144 for colonoscopy, when if, in fact, if I went in and asked for the cash price, I would pay $782. There's something going on there I don't understand. Help me to understand that. And as employers, that's what we will be doing. Second thing to add value is focus on prevention. You will find that the number of preventive care services that you are currently seeing among your population are much lower than they were pre-COVID. And we've got to do something about that. That doing something about it means we've got to find those cases earlier. And to do that, we've got to change the paradigm to where employees actually feel comfortable again about going and getting the types of preventive screenings that will reveal particularly cancers in the early stages versus the late. A third value add is to learn more about biologics. Now, biologics you'll hear a lot about. Our own Texas oncology centers recently did a study involving 450 physicians and oncologists. And what they did was provide patient education and clinician education about biosimilars. And then they took 3 biosimilars and substituted those for the originator biologics. After 1 month, the cost of care was reduced by 21%. That equaled $4 million. Now, 20% savings on biologic treatments, if you look at your data, you'll see that that is accounting for a lot of money for you as an employer to be able to put to other types of value add benefits. And it will pay you substantially to find out more about these biosimilars and start asking the right questions of your carriers in terms of what are the policies about the use of biosimilars. And I need to understand, should I be covering the biosimilars versus the originator biologics for particular patients out there? And how are you as my carrier going to help me to understand that and put in the programs? So I want for you to learn more about the biologics. And I'm going to turn it over to Kim. Kim has a great presentation about biosimilars and how they interplay with the biologics. And we'll let Kim talk about it, and then we'll talk a little bit more. So Kim?
Sandra, thank you so much for teeing me up beautifully, because I am very excited about the opportunities that all of you have now in front of you to manage trend by not compromising clinical care by looking at biosimilars. So I could spend hours talking about biosimilars because of the opportunities within this space. You can flip to the next slide, Marianne. But before we get really excited about the topic, I want to just make sure we level set so everyone understands what is and what is not a biosimilar. So forgive me if all of you guys already get this, but I find oftentimes there's still confusion around what a biosimilar is versus a generic, and they are not the same, right? A biosimilar is not a generic drug. They are not interchangeable with the innovator product, right? So that's a really important thing to understand, because like to Sandra's point, she in her experience saw that 21% savings on a biosimilar change from an innovator product. That's a really solid savings number when looking at a biosimilar strategy. Overall, you could see 25%-ish, depending on what type of strategy you take with looking at biosimilars. Whereas you guys know, like in the generic space, the savings is 80%. Sometimes more than that. So they're definitely not the same. So to kind of, again, level set, clinically, they're both the same. So a biosimilar and its innovator product are both the same. They both have an FDA approval. They both have equal efficacy, right? So the outcomes that are expected from the treatment are the same, whether it's the biosimilar product or it's the innovator product, right? So I think it's just really important to kind of level set. They're not generics. They are almost equal. But like if you're moving to a biosimilar product, the doctor does have to write a different prescription for that biosimilar, whereas generics are interchangeable. The pharmacist can make the change for you, depending on data codes, but we won't get into that detail. I think the exciting part about biosimilars is they're just now going to become the hot thing in the United States market. They've been around for years, almost a decade now. Actually, yeah, almost a decade now. So I think it was back in 2016 from memory, our first biosimilars got approved in the US market by the FDA. We have not adopted those into the marketplace yet. There's a lot of litigation still going on around patent protections and a lot of that that's going on that's preventing them from actually coming into the US market. I think there's hesitancy still. So I love others like Sandra that's going to provide education on the value of these products and that there is equal efficacy when you're looking to a biosimilar. They've been in the European market almost since they were approved. So there's a lot of good quality study outcomes to show the value of the biosimilar product in the outcomes of that patient, meaning side effects are the same. There's no changes in any of that. So Marianne, we can flip to the next one. And I'll just kind of lay the ground. There's a different, or ground level, there's a different approach you can take to a biosimilar management strategy. So you just need to educate yourself, get a good partner that you can trust, and then decide what your approach is going to be. We at Blue Cross Blue Shield of Michigan prefer the lowest net cost strategy. So that's how we manage all of our drug lists. That's not consistent, and I won't say we're doing it right and someone else is doing it wrong. It's just our model, and that's how we choose to pursue our strategy of all drug lists in all drug categories. There's opportunities if you want to chase rebates. This is going to be a really nice space to chase rebates because there's going to be rebates provided both on the innovator product and there's going to be rebates on the biosimilar product. So we are going to look overall what's least expensive after you look into the rebate implications, after you look into the discounts that we're going to are able to negotiate with the manufacturers. But again, there's other models that chase the rebate dollars and they want that big fat check at the end. So you just have to understand, what your preference is and how you want to approach your biosimilar strategy, and obviously work with whoever's arranging your benefits. But as of first quarter of this year, there were already 29 biosimilars approved to date in the market. So that's exciting. There are 17, Sandra, you talked about oncology. So there are 17 oncology biosimilars that have launched to market. 5 of those are for oncology products that are innovative products. So this is really, really exciting. Everybody knows the cost of cancer is insane, right? Cancer drugs are on everybody's top list of spend. So this is going to be a really nice opportunity for us to start controlling that spend trend, right? And then doing our part to manage without having a negative impact to the member, which is a big thing for us as well at my plan. When we were looking at our strategy, we tried to look at the top drugs and cost, right? So you see them ranked down on here. I left my notes for myself on there in red for you, so you guys will benefit from them. So you can see that both Avastin and Herceptin are always on the top list. Both of those are for breast cancer. Rituxan is a medical benefit drug. I can tell you that Neulasta for us falls on both sides of the benefit, depending on the form of administration that it's being prescribed. So this is actually, Neulasta is a good example, but this is actually going to be a nice integrated solution for anybody that's looking at keeping their pharmacy benefits as part of their medical benefit, because this is just going to blow up. Enbrel and Humira were the first drugs, I think, to get FDA approval of biosimilars, again, back in 2016, I'm pretty sure. So right now, from memory, we've got 2 biosimilars that have been FDA approved for Enbrel, and there's 6 that have been approved for Humira. So that's exciting because those 2 are on everybody's top spend list. So this is an opportunity to start looking at opportunities to model out how you're going to take full advantage of these products when they're available in the US market, which we're thinking 2023, if all things go well. So there's a couple models you can take in your approach. You can look at making the biosimilar innovative product at parity with how you have it tiered on your benefit structure. You could prefer one or the other. You can go with an exclusive arrangement. And any approach is going to give you, to Sandra's point, rebate advantages for whatever product you're making exclusive, whatever product you're making preferred, whether it's the innovator product or the biosimilar product. So to say straight out the gate, all biosimilars are going to have a lower net cost is not an accurate statement. There have been some that we've looked into, we've not launched into our biosimilar strategy because the lowest net cost, after you look at discount improvements, after you look at rebate improvements, actually it's an innovative product. So you have to just understand that there's going to be some fluctuations and differences, and just have dialogue with whoever's helping you arrange your benefit. I mentioned we're excited about these opportunities to really look at what we can do to bring the additional value of an integrated solution. Side effect profile is super important, right? You want to understand that. All the ones that we're talking about today have equal side effects, right? The efficacy is equal, the side effect profile for the drugs are equal. We always look at disruption. We're super sensitive to our members, and we want members to be very happy with us. So whenever we're looking at our strategies and how we're going to roll out, you want to take that into consideration. We have to keep our doctors happy so they continue to treat our members. So we're sensitive to that as well. And again, like I said, look at overall savings, overall impact, and that includes the rebate implications and what's coming in the pipeline. Right? So you might make decisions today and then miss out on an opportunity for a new biosimilar that's going to become available next year. So all of that needs to be part of your strategy considerations. So Marion, if we go to the next slide, I'll fill you guys in on how we kind of dipped our toes into the water. So Remicade for us, number one, highest spend drug on the medical benefit. For us, we're spending about $140 million annually on that drug with about 23,000 annual infusions of Remicade. So it's a big hitter. Pfizer launched Inflectra, and this is a beautiful example of thank you for the European market, because it's been over there doing great for years under a different name. And so we were able to take the studies and the outcomes that are available from practical use in Europe and start sharing those with our provider community to gain buy-in to we can switch to Inflectra and not have a negative member experience, and not keep all members on Remicade for significant savings. So we started our approach by working with providers so that, again, member sensitive. I don't want the member to be the one responsible for calling the doctor saying, hey, my plan doesn't cover this, I want a new prescription. So we approached it from the provider perspective rather than putting that onus on the member. Super successful program. We launched this in 2019 as our first dip in the water, and had no pushback. We had interesting, only one physician group that sent back a letter questioning our practices. We were able to send, again, plenty of outcomes, plenty of studies, plenty of feedback from the other providers across the state and across the country that were serving our members that were having supportive feedback from the transition. So for our HMO business, we transitioned 91.3% of our members within the first few months of the program. For our PPO members, 86.6% of our members transitioned. We excluded pediatrics. So University of Michigan, obviously in our back door, we partner with them a lot on clinical programs. We pilot a lot of initiatives with them, and they were the first ones to say, don't touch my peds, right? There's not enough studies to support this first dipping your toes into the water with this initiative. So we excluded those, and that's why you see some of the numbers a little bit lower. If you compare this to one of the very large employer groups that we partnered with on this program, they had huge success with it, right? For their HMO population, 100% of their members transferred with no issue. And on their PPO side, 81.1% of their members transferred with no issue. So for them, again, very large employer group, national customer, they saved almost $5 million. So that's real money, right? That's real dollars. And again, a program that caused no disruption for their member population, and is pretty easy to roll out. So we obviously are going to continue to look at the biosimilars as they come to market. We've got an army of folks that are monitoring the pipeline, and we continue to expand. So since the launch of the Pfizer product, we moved Herceptin into it, Neulasta, Avastin, and Rituxan were the next innovative products that we targeted for our biosimilar strategy and had equal success with the launch of those products as well. Because again, we had tested it with the one drug and then got our provider communities comfortable with writing for biosimilars, and again, working with the provider community to make that transition and not put that onus on the member. So if you want to flip forward, again, I kind of touched on this a little bit. There's different approaches and how you can come to the lowest net cost for you or whatever the savings is you're going to get. There's opportunities to adjust payment schedules, again, both on the biosimilar product and the innovator product to kind of get things going. Once you have significant market share or you're seeing a big shift in your market share, there's always opportunities to renegotiate your discounts and your rebates. So those are like the what's. And then, like I mentioned before, you got to remember that there's rebates on both products. So don't get so focused on just the biosimilar product that you neglect maybe what will be a lower net cost solution for you with the innovator product. So you want to always be doing your homework. What works for one drug may or may not work with the next one. So keep your eyes on that. And then for us, we were super, again, member centric. Any of our members that were currently in treatment that we did not require any changes for them, obviously we allow them to finish their treatments. So we did some grandfathering. So that's a consideration too that you want to take. And can you reach out to your provider community? Do you have a relationship where you can kind of shift the program or shift into the preferred lower net cost option for you with the providers taking that initiative rather than it being on the member? So kind of just to wrap up for you guys, just recommendations, whether, from my employer partner or whether it's from Blue Cross, really important to trust the information you're getting, really important to make sure that you're partnered up with someone who's going to be able to keep up with the pipeline and keep up with the changes in rebate opportunities and discount opportunities that's going to help you foster your program to take advantage of the significant savings. You also want to make sure you are in alignment with whoever's supporting you. Are we chasing rebates? Are we chasing low net cost? Do you want to have, parity and you'll take a lesser savings by having that approach? There's options. But again, for us, the member communication piece was super critical. You saw the outcomes from my employer partner that we launched this program with. They were really successful, 100% transition of market share because they really emphasized the value of this with their employer. So they didn't just do what we were doing with the provider community. They were adding a lot of additional education to their members on it's safe, it's equal efficacy, the side effects are the same, it's okay to change. So a lot of that education, I think, coming from them definitely helped their numbers to boost up a little higher than our book of business numbers. So I hope this has been helpful for you guys. To Sandra's point, I think too, you mentioned the importance of clinical efficacy, that that is like got to be the foundation of everything that you do. Not just because, I'm the health plan representative, but I've been in this business for a really long time. And I've been in specialty pharmacy. I've worked as a consultant, providing guidance to employer groups and health plans all over the country on these type of topics. In clinical efficacy has got to be your number one thing. You don't want to be one of the victims of the study that Sandra quoted earlier, where you're saying 70% of the drugs are ineffective. It means those members are not on the right drug, right? It means that the clinical studies weren't researched before those drug lists were established. So you don't want to be a part of that population, right? So just make sure you don't want your members to be a part of that population. So make sure that whatever strategy you pursue, that it's clinically sound and you've got those that clinical evidence to back it up. So again, hope this has been helpful for you. I loved being here. Super great to see Sandra and Marianne again, and I will hang out and be around afterwards for questions.
Perfect. Thank you, Kim. I think you saw an example here of one of the value add strategies that, again, it's important to learn about it. It's important to have the right conversations with your carriers about it. And as Marianne said, for 25 years, I managed the design and implementation of employee benefits for Procter & Gamble. And our CEOs were wonderful people. And one of the things that all of them had the strategy of was they didn't reward us for doing our job. They rewarded us for being strategic thinkers. And one of the things that they would do they would come up with an announcement. And a lot of times it would happen on Friday. And it would be something to the effect of, by next Friday, I want every sub-department within every department of our company to come up with a strategy for how you're going to save $5 million. That was always a challenge. It gave me the weekend to think about, but you just saw a strategy that will say it could save your company $5 million. And it was with one specific biologic drug. So the value is there. It's just a matter of knowing what to ask, how to ask, and what to do with your design. So let's pull these pieces together. I said as earlier that Mr. Rogers' mother always told him to look for the helpers. And what's going through your mind now is, okay, I've heard several different things here about ways that I can add value, but how do I do it? Where is my help? You know, these are one of many things that are on my plate. So what can I do? Where do I go? Where do I look? And so I want to talk a little bit about one of the helpers that's out there, and that is, next slide. That is the Get the Medication Right Institute. And Marianne referenced the Institute and told you that Dallas Fort Worth Business Group has been working with the Institute as one of the employer advisors. As part of the development of the Institute, there was a study done in the 2015-16 timeframe that looked at waste within the system. And it looked at what is our current delivery system for medication use and where are the opportunities. And one of the results of that study was the realization that $528 billion is the cost today of non-optimized medication therapy. Obviously, that was the cost today in 2015-16. It's even greater now. And you could see some of the breakouts of where those costs are. When a drug is not the right drug for an individual patient, you're going to have ramifications from the use of that drug. And those things include hospitalizations and long-term care and emergency room visits and all of those types of things that add up to $528 billion. Medication therapy problems. There's all kinds of problems out there. Non-adherence. We all talk about non-adherence and how important it is. And if you talk to your PBMs, for example, that's one of the first things they'll come up with is, let's fix the non-adherence. Well, if you look at this chart, non-adherence is a piece of the pie. It's 15%. There's other things going on that are also contributing to medication therapy problems. Doses too high, doses too low, not the right medication, et cetera, et cetera. So next slide. When we looked at asking the people who will benefit most from the Get the Medication Right Institute, we said, you know, what is some of the things? In a recent survey, we asked questions of primarily employers, but others also. What's the biggest issue with managing medications right now? 50% of the respondents said lack of communication between prescribers and pharmacists. Think right now, how much communication do you think is currently happening between a physician and a pharmacist? Not much. Other part of it was, of course, the cost of medications. And a lot of that has to do with that lack of communication that goes on between the physicians and the pharmacists. Next slide. What should be the first step in changing the way we manage medications? 33%. Physicians working in a collaborative practice with pharmacists to help patients reach their optimal goals of therapy. And you can see the breakdown of some of the other things that were also identified as being important changes that need to be made here. Access to the clinical information at the point of care. Looking at payments and what are we paying for today versus what should we be paying for today. Next slide. So in 2019, the Get the Medication Right Institute was launched. And the vision was to enhance life by ensuring appropriate and personalized use of medications and gene therapies. And the mission was to bring all of the stakeholders who had a stake in getting the medication right together to work on the ways that we could, in fact, achieve getting the right medication for the right patient the first time. And you can see the focus areas that the Institute are currently focusing on. We have work groups within the Institute with all kinds of different stakeholders in each of those groups that are working towards looking at the solutions to the current trial and error system of medication use. And that is what we have today. A physician, think about it, when you go to a physician, what do they say? Well, let's try this drug. And if it doesn't work, try it for a month. If it doesn't work, we'll try a different one. And if that doesn't work, we'll try another different one. But what are the other things that could be being done that would tell that physician the first time what the right medication would be for an individual? Next slide. What the Get the Medication Right Institute is promoting is something called comprehensive medication management. And what that means is it is a systematic approach to medications where physicians and pharmacists are ensuring that the medications that a person is taking, whether they're prescription, over the counter, alternative, traditional, vitamins, whatever that person is putting into their body, is first of all appropriate, and secondly, safe, and that all of the comorbidities and other things that can be influencing the use of medications by an individual is being analyzed and interpreted by the right team of medication experts. Next slide. So what happened out of this were many things, but one of the things that directly influences employers is we had 8 of our major employer coalitions that got together and developed an employer toolkit. And this toolkit explores this concept of comprehensive medication management as it relates to employers from the very beginning of, comprehensive medication management 101. What is it? What does it achieve? Who's involved? All the way through the process of how do I, as an employer, approach my PBM or a separate vendor or any other source that's out there, a school of pharmacy in the community, anyone that could actually help me put in place comprehensive medication management for my employees and their family members. So I would encourage you, the link is here for the employer toolkit. And as I said, it's a pretty comprehensive employer toolkit that is being improved on a almost daily basis. But I would encourage you to take a look at that. Next slide. So what can you do as an employer now? The future is coming, and it is going to change the way that medications are used today. But for you to be ready for that change, there's some things that you should be looking specifically about in terms of your contracts, in particular with your carriers. So one of the things that should be put into your contract is that you, as a vendor of mine, must coordinate care with my other vendor partners in order to achieve the clinical outcomes and make sure that my patients get the right care in terms of both medical care as well as prescription drug care the first time. Prior authorizations should be inclusive of appropriate diagnostics. Now, folks, there's a list that the FDA has that has hundreds of medications that have what are called diagnostic indicators, which means the FDA is saying for this drug to be utilized, this particular diagnostic test needs to be done. Some of that is pharmacogenomic testing, meaning looking at a person's biological makeup and making sure that that drug is an appropriate drug for that individual. If you look today, and I would encourage you to ask for some of your top leading drugs, to ask for the prior authorization protocols. One of those protocols should be, has this test been performed? And if the answer is no, that is a stopping point in the care of that patient that needs intervention. The test should be done. Those tests are there. They're very precise today, and they will tell you right up front whether or not a medication is going to work appropriately for the individual patient that it's being prescribed for. Clinical pharmacists should be in collaboration with physicians within your contract. Go back to your PBMs and say, how are clinical pharmacists involved in the care of my patients, of my employees and family members? And have them explain to you, what do their clinical pharmacists actually do? And how much intervention is there happening between that clinical pharmacist and an actual prescribing physician? For example, if that prior authorization protocol says there should be a diagnostic test and that test has not been performed, then that's a stop in the prior authorization. A clinical pharmacist should be stepping in at that point, getting in contact with that physician and saying, this test will help guide the care of your patient and help us to understand whether this drug is actually going to help or actually going to harm your patient. Now, you would think physicians should already know these kinds of things. Medical technology, medical knowledge is duplicating once every 70-something days now. It used to be years, now it's days that it duplicates. There is no way any one physician could ever keep up with the changes that are happening in medical knowledge. So that's why we need to step up today and say, time out. We should not be practicing in silos out there. We should be combining the experts. And the physician is not the expert on medications. The physician is the expert on medical care. The medication expert is that clinical pharmacist. Clinical outcomes, are they being reported? So you prescribed this $100,000 medication for my patient. You PBM filled the prescription for that $100,000 medication for the patient. What's being measured to say that medication is even actually working? And if it is not, who's going to stop it? And at what point in the process? After I've already spent $100,000 on the particular med that's not working, that is pure waste in the system that needs to be eliminated by doing the right thing. No financial penalties for validated right drugs. What that means is, you know, those formularies that are out there? Well, the right drug for a patient may not be a formulary drug. It may be actually a different medication that is not on the formulary or is on a different tier within the formulary. So are we as employers acting prudently when we say, oh, well, we'll go ahead and cover that drug under the plan, but we're going to cover it in the lower tier. So you, patient, are going to have to pay more to get you the right medication the first time. That doesn't help the patient. That doesn't help us as employers. And then the lowest patient plan costs without rebate should prevail for a validated drug. So again, if a diagnostic test tells you a particular drug is the right drug for this patient, then we should not be looking at the cost of that drug with rebates or without rebates. We should be looking at what is within that category of drugs, the right drug at the right cost, and how do we get there? So next slide, we're gonna wrap it up here. So include the important pieces, and you do that through comprehensive medication management. The clinical pharmacist is the one that will know the appropriate diagnostics to do for a particular drug. You have to be the one to say, I want these diagnostics done, as part of the prior auth. And maybe it does slow the amount of time that it takes for a patient to get on the drug. But explaining to the patient that this diagnostic test is going to tell us up front whether that drug's going to work and whether they are going to be able to tolerate the drug from a genetic and metabolic standpoint is important education for them. Next slide. So again, this is just a showcase of what I said earlier. Remember when I said only about 30% of the drugs that are prescribed for an individual will actually work for that individual. And we're not just talking specialty drugs. We're talking drugs of all different types. So again, this slide in itself tells you why those diagnostics are important to include in your plan design to make sure that they're being done and that if need be, the physicians are being educated about doing those and the importance of doing those prior to prescribing a medication and that medication being filled the first time. Next slide. Patient knowledge and trust. That's huge. And the people that are able to develop that patient knowledge and trust are not the physicians. In a 15-minute office visit, studies have shown that a physician spends 40 seconds talking about a new medication. That's not building patient knowledge. That's not building patient trust in that medication. We've got to have a team that is able to take over and do that type of knowledge and trust building with our patients. Next slide. So this is just a pictorial of what comprehensive medication management is and what it involves. I'm not going to go through each of those and for the sake of time, but as you can see, it's not the medication therapy management that you see as part of Medicare. It's much more involved in that. It's done by a team and it's a repetitive process so that on an ongoing basis, a patient is being monitored by the right people. And it's not every patient, it's patients that are appropriate for comprehensive medication management, but they're being helped along the way by the helpers. Next slide. Next. So ability to pay, that's the last thing that I want to mention in terms of how comprehensive medication management can help. We do a lot of things that are contradictory to our patients being able to, and our members being able to pay for the medications that are prescribed for them. We want to first make sure it's the right medication, but secondly, we want to know that they're able to afford the medication. But we're doing things like copay accumulators and those types of strategies that we feel are necessary because we want parity within our plans in terms of people not getting credit for payments from manufacturers that are not being counted towards deductibles and or not being taken away from deductibles and copay aggregators and the total cost of care, et cetera, because other patients don't feel that that's right. But at the same time, there are companies out there that are able to assist your members to actually get the right kind of support financially for being able to afford the medications and do it in a way where they don't get 6 months into the plan year and suddenly their help from the manufacturer runs completely out and now they're posed with the entire cost of the medication. So again, these are the types of companies that you should be gaining some knowledge about and looking at how do they interact with your plan. Next slide. And I'll leave these slides. This is just one example of them and how the process works with both setting it up with a plan vendor as well as working with the patient, which is the next slide that comes up. And that's the patient experience. Sometimes they qualify, sometimes they don't, but they're not the ones trying to struggle to find the help that they need from a financial standpoint to be able to get the medications that they need to take on an ongoing basis. Next slide. So we look at help us answer Is this the right medication for this person? And I want to go back again to reinforce the diagnostic piece of this, because that today, folks, of all the pieces of the puzzle that are missing when it comes to comprehensive care of patients and the right care the first time, the piece that is really the huge piece that's missing now are the diagnostic pieces of it. So I would encourage you to, again, use your slides, take a look at them, and look back through some of the data that I've provided for you today. Next slide. And this is just the contact information for the Get the Medication Right Institute. Again, the address is www.gtmr.org, and that will take you to the home webpage. And within that, you'll be able to access a lot of different information, but more importantly, the employer toolkit that your organization was a part of developing. So thank you for listening, and I'll turn it back over.
Oh, that's great. Well, thank you very, very much, Sandra and Kim. This is a very enlightening and probably too short of a discussion. There is so much that you covered and so many questions. I have a few. For example, the PBMs play such a big role in whether it's biosimilars or getting the medications right. And I think I have time for maybe this one question. How, I mean, I know that, I think, Sandra, you mentioned about the rebates, and so did you, Kim. You know, that drives a lot of the formulary decisions. How resistant are they to even the biosimilars? Are they embracing them? Kim, you might know the answer to that.
So you want me to take that one?
Yeah, if you don't mind.
Yeah, perfect. So there's so much, there's a lot of opinions around rebates and whether they're good for us or bad for us. But the reality is they are part of us, right? This is part of the life that we live right now, like it or not. So they need to be an important part of any strategy. So, you know, from my plan, we do everything clinically first. The folks making decisions from a clinical perspective from our P&T committee have no purview into the financial impacts. So all decisions for us are made based on clinical efficacy, side effect profile, other drugs in a category, all of those things first. And then after what is decided from a clinical safety perspective, then that's when we start making decisions based on discounts that are available or rebates that are available. And I don't see rebates going away anytime in the near future. Again, like them or don't like them, they're part of the pricing strategies that are in play today. And so you definitely have to have those as part of your decision making when you're trying to decide whether you're going to have a rebate driven decision or whether you're going to do an overall lowest net cost. It's still a play in both of those scenarios.
Okay, that's helpful. And with Get the Medicines Right, I mean, wow, what you cover, Sandra, is just amazingly important. But the big question is, well, yesterday we had the program on advanced primary care models, and nobody mentioned, and I didn't have a chance to ask this, anything about, I mean, they talked about having the team involved in the collaborative care model, including a behavioral health specialist, professional, whether it's a psychiatrist or in coaching or whatever. Not a word about the pharmacy side, and yet the pharmacy component of a medical visit to any physician is so huge from what you just described. How are plans and employers, how can we get the physicians to embrace the pharmacogenetic testing, for example, to make sure it's the right, or adherence and all the other things that make the outcomes much more likely to be the right outcome?
Yeah, that's a good question. I think the Get the Medication Right Institute is all about, you know, getting that into the actual practice. As a matter of fact, they are establishing a physician advisory board that will be focusing specifically about, you know, how do we help educate physicians about, first of all, you know, the drug card that the patient has is not a magic card. Someone is paying that cost. And, you know, today that someone is both the patient, because we have shared value, you know, shared cost between the employees and the employer, and that cost varies every year based on your previous year's cost. Well, if they're out there prescribing the medications without the diagnostic testing, and you're spending thousands and thousands of dollars on medications that are not achieving clinical outcomes, first of all, you've got a huge waste of money. And second of all, you've got a patient that is not improving at all because it's the wrong medication for that particular person. As a matter of fact, they may actually be getting a lot worse because of the comorbidities that are there, as well as the side effects of the drugs they're taking, and all of which are happening for no reason. So we have to get to the point of again, educating physicians. And one of those ways that I would encourage the coalitions to do is to get together, and as we have done with the toolkit, and talk more within your conferences about these types of things. What, as an employer, should I be asking directly of my medical carriers and my prescription drug benefit managers, or they may be a combination? Because particularly with specialty drugs, we pay a lot of attention to the PBMs, and they report a lot of data. Your medical carrier is not reporting hardly anything. And if you really look at specialty drugs, the greater spend is happening on the medical side. So that in itself is a scary thing, because we're focusing on the lesser of the evil, if you will, in terms of what's going on. And I can assure you, in the medical setting, that no one is there saying, wait, time out. Shouldn't we be doing this test first to determine if we want to administer this drug in the hospital to the patient? No one is there asking that question. It's silly. When we talk about medical care, we send our people to the experts. The experts, when it comes to medication therapy, are clinical pharmacists. We should be enveloping them into the actual care of every single one of our people, so that we know that the person with the best knowledge is actually asking the questions and coordinating the care with that physician.
Terrific. That's a perfect closing to a very informative session. So I want to thank you, Sandra and Kim, for participating in this. It's been just a delight hearing everything. No, not a delight, scary hearing everything that you're describing. So, but you have given us some good guidance on taking the first steps, and I appreciate that. The toolkit is really important, I think. We're going to post that on our website. I don't know if we've already posted it as an important resource. So those who have seen it today, to explore that in more depth, it sounds like that's how you're going to ask the right questions. So with that, I want to thank all of you for participating in this year's Regional Benefits Forum. Virtual though it was, hopefully next year it can be in person. But I will say on September 30th, we are having our first back in-person educational program, general membership luncheon at the Omni Park West, and it's on the role of benefits in supporting a healthy and diverse workforce. I think you'll find it very interesting. We have an expert in this area, Dr. Carol Scott, who comes from Johns Hopkins, to come and talk about the DEI, which is the new acronym. This is healthcare, acronym for everything: diversity, inclusion, equity, and inclusion. So it's a good one. Register online. And then the next slide, please, talks about our annual forum. Save the date. December 2nd is our annual benefits forum. Texas Business Group on Health and DFW BGH put it together. It's a one-day program at the Urban Convention Center, again, in person. Hallelujah. And so we're excited about that. Save the date, and we'll have more information coming to you soon. So with that, thank you again, all of our speakers who may or may not still be on the line. All of our sponsors, thank you, and for helping us put together a sensational program this year. Have a good rest of the week, and we'll see you hopefully on September 30th for our luncheon and December 2nd. Bye now.